Hello and welcome everybody. I'm so glad to have Sharon Jung with us today. She is a nurse practitioner at Puget Sound Neurology, and she's here to talk to us about Duopa. It's something that we get questions about, and we really just wanted to make sure that we had an expert on the topic, let you know what it is, how it works, who's a great candidate for it, and how to get more information if you want to check it out. So welcome, Sharon. Thank you so much for being here.
You are so very welcome. I have been a nurse practitioner for 20 years, and I have been working with Parkinson's patients for most of that time. I love my practice. I love my work with Parkinson's, and I look forward to coming to work every day. Parkinson's disease patients have a lot of challenges, and my patients make me stronger. So, there has been a lot of change in attitudes in the 20 years that I have been practicing and working with Parkinson's patients. And to start out with, Levodopa in terms of treatment is the gold standard. And that can become less and less effective, but the problem is not the fault of the Levodopa, it is the fault of the disease. And I want to go into that and how we have the capacity to solve many of those problems with the Duopa pump, or it's also called Duopa. Backing up a little bit, Parkinson's disease, as we all know, is a progressive disease. And most people do agree that it starts actually in the gut, in the intestinal area. And then there is the pathology in the brain, and the pathology in brain continues to spread. And with that pathology comes constipation in gut that does not want to move. In fact, a lot of people report loss of sense of smell and constipation even before motor symptoms begin. The cells that are damaged are dopamine producing cells, and there are a lot of other neurotransmitters that are impacted by disease, but the whole dopaminergic system is what we understand the best and what is most easily treated. So that is why carbidopa, levodopa is such an effective treatment. We are really just replacing dopamine that brain is not making. So with many people, most people, in fact, we start them on carbidopa, levodopa, and they think we walk on water, and that's always nice. And then after a certain period of time, people start telling me that they are wearing off, or they have times in which their carbidopa, levodopa doesn't work. And then sometimes they say it works just fine, or sometimes it works sometimes and not other times. When I get up in the morning, I can hardly move. Lots of problems like that. And we have always kind of blamed the levodopa for that, but that is not the reason. Now, when I say levodopa, and then sometimes I say carbidopa, levodopa, that is one in the same. I just kind of get lazy sometimes. So just remember that levodopa and carbidopa, levodopa are one and the same as far as our purposes. With that comes just a lot of, a lot of difficulty. Throughout the years that I have been practicing, there has been a lot of swinging of the pendulum in terms of the treatment with carbidopa, levodopa. There was a time where we say, well, don't start carbidopa, levodopa early because it only has a limited lifespan, and then the pendulum has swung the other way. That definitely do treat with carbidopa, levodopa. So patients have a lot of questions. They say, you say the one thing, another person says another thing. And so I think everybody agrees on the best care of Parkinson's Parkinson's patients will do the best with whatever it takes for them to be active and vital. For that reason, I am never hesitant to use carbidopa levodopa if it is what people need to do the best. Carbidopa levodopa cannot absorb in the stomach. Our stomach is too acidy in order for it to be able to absorb. It absolutely must go through an obstacle course. And that obstacle course involved going uphill to get out of stomach, getting into the area called the duodenum, and then it has to make its way to jejunum. And we've got a stomach that is moving slowly, sometimes not very dependably. And we've got also food component, and people must eat. But I have patients that are almost afraid to eat because they know that it's going to slow down the absorption and decrease the efficacy of carbidopa levodopa. Remember that the role of fat, which we all need, which is good, no matter what some people think, we all need fat. Fat slows down the emptying of stomach. So that's going to make carbidopa levodopa absorb more slowly and less consistently. And then you have the whole role of protein. That is another barrier. The protein in the levodopa compete in bloodstream to get to brain. The protein wins, and I'm glad the protein does win. So you've got all of these barriers to carbidopa levodopa working, and it's amazing that it works at all. We're very lucky that it works. I always say to my patients to take their carbidopa levodopa separated from meals with a full glass of water. And I tell them that from the word go. And actually, that is so important that I actually had my daughter had make a cartoon out of it. Did I ever show that to you? Josine, okay. Yeah, she has made a cartoon out of it. And I give that to my patients, and I tell them to put it beside their pills. Hey, put this as a reminder to take that with the whole water. And some people say to me, my medicine works now. But at some point, we just cannot get around that inconsistent emptying of the stomach. So then it is time, or can be time, if the patient wants it, it can be time for the Duopa pump, which is also called Duopa. Duopa was FDA approved in January of 2015 in this country, and it's been used considerably longer in Europe, and I don't know exactly how much longer. This is a pump in which a tube is inserted into, and it's a very minor surgical procedure. It is placed into the jejunum, right where the carbidopa levodopa is absorbed from. And then it is hooked up into an external pump in an external reservoir. And then the pump delivers the reservoir of carbidopa levodopa right to jejunum, where it is absorbed. This makes a much more efficient delivery. And the way nearly everybody does it is they do not sleep with it. I program a morning dose, and that morning dose is based on the dose that they would use every morning. And then I calculate the amount of medicine that they use throughout the day, and I program an hourly rate. And then they have the option of using what we call extra doses. And so if they're feeling off, they can have an extra dose. And the beauty of the pump is that they do have the capacity to really custom treat their symptoms. Another thing that this solves, and I must say that I'm kind of insensitive in terms that I assume that people can just take their medicine every hour and a half or every 2.5 hours. Carbidopa, levodopa is a inherently short-acting medicine. Now, there are efforts to get longer-acting formulations, and sometimes those work well, sometimes they don't. But the actual carbidopa, levodopa that most of us know, the little yellow pill, is only actually has a half-life of maybe 1.5 to 2 hours. And if people are really sensitive, they're going to do best if they take their medicine every 2 hours.
Quick question. So you said that they have the ability to customize it themselves. You program it, but like
Absolutely.
during the day, if I had it, I would be able to be like, I want another dose, like without anything.
Yeah. There's absolutely. And there is a way that I can program the frequency and amount of the extra dose. And there are setting options for me. Some people want as little as they possibly, they don't want to be interacting with that pump very much. There are people that are gadgety people and people that are not gadgety people, and I really empathize with the people that are not gadgety. I have people that come in with every nuance of this pump figured out, much probably better than the company. And then there are people that say, don't, I'll touch this thing if I have to. And everything in between. I can put them into what is called lock level 2. And with that lock level 2, they have the least freedom, but they always have the capacity to give themselves extra doses. There is something called lock level 1, and with lock level 1, they can actually change the rate of their hourly dosing. They can change the rate, the amount and frequency of their extra doses. And some people want to do that, some people don't. Some people say, I do really well until 4 o'clock, and I am pretty much brain dead at 4 o'clock in the afternoon. Well, for those people, I they can increase their hourly rate, like at 2 o'clock, to compensate for a downtime at a certain time. And then some people may only want 1 cc for their extra dose, but sometimes they want a little bit more for their extra dose. Another thing that is acceptable and that I encourage is their exercise. Well, they can take the tube off. They can just plug it and take it off for exercise. But then, but they want to give themselves an extra dose before and after to help catch up. And they might want to give themselves, say, that extra dose of 2 cc's before they exercise, but only 1 cc, say, most of the time. So there is all of that flexibility. And it is going right to the spot to which it absorbs, so it's just so much more efficient.
Would you say, I mean, are we talking seconds, minutes? Like what is sort of the effect rate?
That's a very good question. Most people tell me that they're off in the morning and they start to feel their morning dose kicking in after about 5 minutes.
Oh, wow. Okay.
I think, I'm not going to promise that. I think that I seem to remember my patients telling me that.
Okay.
Well, I had to chuckle. We all know that there's the protein that has the interference, and the Duopa doesn't get around that because there's still the interference from blood to brain. However, we do have a more efficient way of getting extra carbidopa, levodopa there. And I had one patient tell me that he used to pay for a steak dinner for 3 days, and now he pays for it for 3 hours. So, and that's just, so it gives some people a little more enjoyment. Another thing is, so there are so many messages in our society right now as far as what to eat and what not to eat, and this is for everybody, and it's even more confusing for Parkinson's patients. You have one set of people saying you must not eat dairy, and then you have other people saying dairy is fine. And I say, if you look forward every single day to your bowl of ice cream at night, by all means eat it, and just make sure you tell me about it, and make sure you have the best tasting kind that's out there. But hey, you don't have to pay for some of your nice little indulgences as dearly as you used to have to pay for.
Who is a good candidate and who is not a good candidate for
That's a very good question. A good candidate would be a person who is just not absorbing their carbidopa, levodopa consistently, and no matter what we do, they don't absorb it consistently. And they may have, cramping, they have off time, they get extremely anxious when they are off. They're in very good health otherwise, or even if health is not as good as you would like, but their motor complications, a better way to say this is their motor complications are the cause of them not living well. Because we can solve those motor complications, and not non-motor complications too, if they are carbidopa, levodopa responsive. I have people that get very cognitively slow and very depressed during off times, and those people do very well with carbidopa, levodopa. If it is the absence of levodopa that is causing these people's symptoms, the tube is going to be a very good way to solve those problems. When we talk about people who are not good candidates, first of all, the underlying UNO-1 requirement for actually both deep brain stimulation and Duopa is a person to be levodopa responsive. If a person is not levodopa responsive or not that levodopa responsive, they're not going to do well with this. And most insurance companies require what we call on-off testing prior to the Duopa, and the insurance requirement is that people have a minimum of 3 hours a day of off time. So the whole levodopa responsiveness is that's the absolute contraindication for this. If there is a major problem with a person's digestive system, with that person, I would send them specifically to a GI specialist and say, this is a situation that we have got going on here. Can you tell us from a GI standpoint if this would be problematic or not be successful? The pump does take a certain amount of work to get it set up every day, and it takes a certain amount of agility in a person's hands to be able to push all those buttons and make them work. If a person lives by themselves and has no way of just making that pump work, that person is it's not going to do well with a pump. Now, if they can get the help that they need, that's another matter. But you have to have the capability to use the pump.
So if you, let's say in the morning you put the pump on, is it like you kind of have to fiddle with it in the beginning in the morning, and then you can basically not touch it again till the end of the day?
Yes, yeah, and best case scenario, a person would set it up in the morning. They have to take the cassette out of the refrigerator, warm it up. It warms up fairly quickly. If it's too cold, the gel is too cold to go through. Then you hook it up to the machine, turn the machine on, and then press morning dose. You press morning dose twice, and the morning dose starts delivering the morning dose, and then everything else takes care of itself. Now, if people need that morning dose, that extra dose, then absolutely they're going to want to access this pump and take it out. And they do have to carry the pump with them, and there are lots of different ways to do that, and people figure out what works best for that. And it certainly is it's an inconvenience to carry that pump around. People who cannot live because they never know whether they're going to be on or off usually take that in stride just fine. There's people who have a very, very busy lifestyle could, it might be that much hassle every single day just isn't going to be realistic for them. With patients with really severe tremor, the carbidopa levodopa it may very well not be sufficient to treat that tremor. It will treat most of their symptoms very well. Tremor is maybe not, likely not. So that's a person that if the tremor is the cause of their disability, it's probably not going to be the best idea.
So what are some of the benefits, side effects, risks of Duopa?
Well, the benefits is that you're going to have a vastly improved symptom control. The biggest risks are the risk of that whole tube. I have to say, even though this isn't sponsored by anybody, the risk of carbidopa levodopa is certainly that's a risk to the pump. The thing is, people are already taking carbidopa levodopa. So there's the risk to the carbidopa levodopa that is delivered through the pump is no greater, and in most instances it's going to be less because people are getting it predictably now instead of unpredictably. The tube is something that can block, and there can be tube problems. As far as the insertion of the tube, that is usually a very simple procedure. It is a procedure where it's an hour, and I don't know, it's an hour or two. I've never actually gone into a procedure room where a person had it done, but they're in and out of there. I do not know the kind of anesthetic that is used. Whether it's conscious sedation, I'm not sure about that. But it's quick, and there's a little bit of pain. There's always the capacity for bleeding. There's the capacity for an infection. I have a patient who's doing really amazingly well with the pump, and he's had 2 infections, and we figured it out. It was his hot tub. So they I guess God worked with the hot tub to get less bacteria there, and he hasn't had an infection since. So there's always going to be bleeding. There's always going to be infection, and those are risks of any surgery. And of course, there is the procedure itself. Could something go wrong there? This is a procedure that people are already doing. I was, my practice is in Tacoma, and I didn't mention that at the beginning, but I was sending my patients to Seattle, and then our local Tacoma Radiology, they have interventional radiologists there, and one of their ladies does come and from time to time and says, "Can we help you with anything?" And I said, "Yes." And I told her about this, and the next thing I know, we're talking. I'm talking to their radiologist, saying, "Can you help me in this way?" And they said yes. So it's a procedure that they are already doing, which when you're doing something all the time, it certainly does decrease the difficulty. The real pain is plugged tubes, and they do happen. And so if a plugged tube happens, you have to start giving carbidopa, levodopa orally, and get an appointment with interventional radiology or whoever is doing it and get that tube replaced. No fan, it happens.
What makes Duopa better than DBS for some people? Because I think that's our big question is people.
Okay, that's very good, very good. Personal preference can be a factor, and I can if it's a tremor situation, the DBS is going to be better. One subset of people that I really want to pay attention to, and that is people with significant health problems. I have people who have severe Parkinson's, severe motor fluctuations, and from a Parkinson's standpoint, that is causing their disability. But they might have some heart problems. I remember I had one person, and this was before Duopa was available. Of course, the best thing for his heart condition would have been a nice, regular, predictable exercise program. And he wanted to go to his exercise classes, but he never knew whether he was going to be mobile or not. That person would not have been a candidate for deep brain stimulation. People on blood thinners, there is far less risk. I'm sure that they would need to be off their blood thinner for a much shorter period of time for Duopa. So all of these comorbid medical conditions can make Duopa a safer option. Then I have this set of people that say, I want cure. I have a guy that would be a very good candidate for deep brain stimulation, but he's most sincere about saying he doesn't want anything less than a cure. And he is afraid that if he were to have deep brain stimulation, he would not qualify for a clinical trial that might make the big difference. And so, if that's where somebody is, that's I absolutely respect that. I personally do not know if you take every single clinical trial out there. There certainly are some that exclude a deep brain stimulation, but there are others that don't. So I cannot make a hard and fast rule. However, that there is that concern for some people. Now, deep brain stimulation patients cannot have MRI scans, with the exception of an MRI scan of the brain. You can do that in a special way. If you have somebody who has any kind of another medical condition where they are going to be needing MRI scans to really keep a condition, that's a consideration. For a very, very, very active person who just doesn't have the time to mess with a tube, a deep brain stimulation, or just the strength in the hands, the being able to figure out this pump, deep brain stimulation is probably going to be a better option for them. Both require response to carbidopa, levodopa. Those are the things that come to mind. I think they are both FDA approved for advanced Parkinson's. They are both very good options. And, I think it's just important for people to have as much information as they possibly can and make the decisions for themselves. And that is another thing with both procedures, because I have been working with deep brain stimulation since 2003. So I'm very familiar with both procedures. There can be, a lot of people saying, hey, do this, do this, do this. And I appreciate my patients who say, could you guys please step back and have it be my decision? And I cannot overemphasize the importance of that.
Is Duopa covered by insurance?
Yes, it is. And the procedure for you getting it is the first thing I have my patients do if they're interested. And some of them I've heard of it. Some of them come to me and say, I heard about this. What do you have to say? There is a sign that they can, the form that they can sign. I said sign that they can form, but it's form that they can sign. And that allows for the insurance process to start. And I actually give them a booklet, and the booklet has, I think it's an 844 phone number, not 800, it's 844. That allows them to call patients who have had procedure, and it also allows them to call the company and ask questions. I strongly encourage patients to call and talk to another person who has had the procedure. One thing that made me really happy to hear is that statistically, the statistic I heard is of the people that make that phone call and call a person who's had the procedure, 70% will go forward with it and 30% will be talked out of it, if you will. And I feel like if there is a 30% rate of a person saying, I talked to this person and, I'm just not going to do this, I feel like that is a fair representation, and that I don't feel like somebody's being coerced or anything like that. So I'm very happy to hear that. And then there is the next step is talking to a pharmacy, and they can talk to the nurses from Duopa, and they have nurses in different roles. And like so many other things, the nurses bring, the nurses make the company. And I've had just a lot of very good experiences with those nurses helping me and helping the patients get set up with it, get comfortable with it.
So is there a case where somebody is using Duopa and they get to the point where they're like, either it's not working as well, or they're not liking the system that they have to deal with all the time, and then they stop and actually get DBS?
It works both ways.
Okay.
I've had deep brain stimulation patients get Duopa. I personally haven't had a Duopa patient get DBS, but it does happen. And I don't know the frequency. I don't know.
So the person with DBS actually also uses Duopa for their supplemental medication?
This particular patient was actually had, this is my own personal experience with my own personal patient, had done very well with deep brain stimulation for a while, but the DBS just wasn't working as well, and so we kept adding more and more medicine. And I actually tried increasing the stimulation, and he didn't tolerate that at all. I would never tell somebody to have a procedure or suggest a procedure before I had exhausted the DBS, but we really had. And it was actually, ironically, time for a battery to be changed. So rather than, well, the DBS had to, for whatever reason, just wasn't working well. What I did with him is we said, well, let's see if we can get by without this. And so I started tapering the stimulation little by little, and he's off of it and doing well with Duopa.
Great.
And yes, and doing both. Some people do require both, and I do not know of any contraindication to it.
Great. Is there anything I didn't ask that I should have asked about Duopa?
No, I don't think so. The only thing that I do want to say is that there are 2 other pumps that are under clinical trial, and those are subcutaneous pumps. One is called the apomorphone pump, and that is a medicine called apomorphone. It is the same medicine that is in Apoquin. It is just in pump form. And if people know what insulin pumps are, they are, that's something that delivers the medicine through a needle under the skin. So it's much less bulky than the Duopa, and does not require any procedure whatsoever. Just you have to poke a needle into your skin every day. And then there's also a carbidopa levodopa pump that is under, I'm sorry, it's probably just a levodopa. I don't think it would have carbidopa in it, but that is, that's happening in clinical trials throughout the country as well. And so Duopa is the first pump therapy, but the pump therapies are coming, and they're worth knowing about. It's an honor to be here talking to you about this, and it is an honor to take care of my patients. So you're doing me a huge favor.
Great. Thank you so much, Sharon.
You're welcome.